Hello, everyone, and welcome to another session of vertical integration. And today, the topic for discussion is dengue fever. And for the same, we have a very a knowledgeable panel to discuss the same. And to introduce the panelists for the day, I have Dr. Marilyn Moni, who is a professor in the Department of General Medicine. Dr. Naomi, she is an assistant professor in the Department of Community Medicine, and Dr. Chinnu, she is an assistant professor in the Department of Microbiology. So we'll be following the usual pattern of pre-prepared questions and then discuss any common questions for the students later. I'll start off the session with asking a question to Dr. Chinnu. Chinnu, what is the usual causative agent for dengue, and is there any subtypes, and does the subtype have any clinical relevance?
Yes. So dengue is a disease that is a viral disease caused by dengue virus, and there are 4 serotypes, and they are denoted as dengue 1, 2, 3, 4. Recently in 2013 we have discovered a 5th serotype. But when we talk about serotypes, we are talking about 1, 2, 3 and 4 in general. Now this serotype has its own relevance because when you usually get infected with a viral infection, you tend to develop some sort of immunity against that virus. But the problem with dengue is when you get infected with a serotype, a single serotype, it is called as primary dengue infection. And then your body starts developing antibodies and you are protected against that particular serotype, but not against the other serotypes. So, but in secondary dengue infection, that is when you get a second infection of dengue with a different serotype, your body will not protect you against that particular, against the serotype. And rather you will have a severe form of dengue infection developing because of a different serotype. So that is the relevance. And this is what is making it difficult for us also to produce these or develop vaccines because of this mechanism that is involved in immunity.
So once specific serotype is prevalent, can multiple serotypes be prevalent at the same time? That's
in India, we have all the 4 serotypes circulating. Same holds true for Kerala also. We have all the 4 serotypes circulating. So that's why dengue can turn into a serious infection in India.
Okay. So second question also to you. So what's the usual incubation period, and a quick word about the viral replication cycle and also usual route of transmission?
So the incubation period is around roughly 3 to 10 days for you to develop the disease, show signs and symptoms. Most common modes of transmission are human to human with the help of mosquito, that is Aedes aegypti as well as Aedes albopictus. And then you have very rare modes of transmission. So we have had cases of dengue being transmitted through blood products, blood transfusion, and even through organ transplantation. So in Amrita itself, we have had documented cases of bone marrow transplant and liver transplant, later on the patient developing dengue. So those are the rare modes of transmission. Now coming to the replication of this virus, like any other virus, it enters the human cell, host cell. Then it enters the host cell through endocytosis, reaches the inside cytoplasm of the host cell. Then it hijacks the host cell machinery to produce daughter viruses or virions, and then they burst out of that cell and infect the rest of the cell. So that is like any other virus. But the problem is the host immune response that you see associated with this viral infection. So when the virus infects the host cell, your immune system gets activated and they will start developing neutralizing antibodies like any other viral infection. In addition to that, your body will also start developing non-neutralizing antibodies in dengue. It is this non-neutralizing antibodies that is causing the massive problems that I was already said about the serotypes. So what they do is, these non-neutralizing antibodies during the first infection, both of them will be developed. So neutralizing will kill the virus and protect the person. Now with the second serotype, when you get infected, these non-neutralizing antibodies, instead of killing that particular serotype of the virus, rather it protects that serotype from the host immune system. So what they do is they will prevent B cell activation, and therefore they will also recruit more mononuclear cells into the body so that there is a massive cytokine release. That is why you manifest it as a severe dengue disease in the secondary infection.
Okay. So now, since we got some idea about the viral agent, it's time to move on to the vectors. Dr. Naomi, if you can tell us something more about what is the usual vector, and is there any geographical or basic behavioral characteristics of the vector?
So the vector, as Shiha mentioned, is Aedes mosquito, primarily Aedes aegypti and Aedes albopictus. These mosquito belong to the family Culicidae, and they mainly prefer human beings for their blood meal, and they are mainly found in the domestic as well as in the surrounding areas. And these mosquitoes are also called as tiger mosquitoes because of the presence of the stripes in their body as well as the legs. Coming to the seasonal characteristics, they are commonly seen during the rainy season, that is the monsoon season. So the peak of the epidemic is seen more during the June, July and August months of the year, and there is a decrease in trend post monsoon season. Then coming to the geographical distribution, the disease and as well as the vector is more commonly seen in the tropical as well as subtropical regions, and they prefer urban and semi-urban areas, mainly due to the presence of vector breeding sites. The vector breeding sites are commonly seen. The vector breeding site for this Aedes mosquito is artificial collection of water, so mainly seen in the leftover containers, coconut shells, bottles, abandoned tires and all. So this is the main vector breeding sites.
Okay. To Dr. Merlin, once a person gets dengue, so what are the usual clinical features and examination findings one should be looking after?
So, dengue typically manifests as fever with myalgia. So, the myalgia which is described in dengue is typically low backache, and it is typically called as breakbone fever. So, the myalgias and the low back pains, in addition to generalized muscle pains, and sometimes some patients may have prominent joint pains as well. So, in addition to that, patient can have headache. So the typical headache is a generalized headache, and it can have a typical retroorbital localization, and patient may complain of pain while moving the eyes. And also patient can have neck pain as well. In addition, patient can have GI complaints like vomiting, abdominal pain and severe lassitude. And some patients can present with confused state, with lethargy, and sometimes features suggestive of an encephalopathy, as in an altered sensorium. It depends upon the state at which, or the involvement, the stage at which the patient presents to you. The initial symptoms might be this constitutional symptoms, but as the disease progresses, the patient can have symptoms suggestive of complications. The most prominent complication of dengue, as we all know, is the bleeding tendency, which is produced by the lowering of the platelet counts. And this typically occurs after 45 days of fever. So once the platelets come down, patient can manifest with mucosal bleeding, and sometimes can manifest with severe internal bleeding as well. So the mucosal and the minor sort of bleeding manifestations are the petechiae, the purpuracine of the skin, the subconjunctival hemorrhages, the oral bleeds, the epistaxis, etc. However, some patient can have fatal GI bleed, and some may even present with intracerebral bleeding and the symptoms pertaining to that as well. Now, in the stage of capillary leak, they can present with features suggestive of ascites and features suggestive of serositis with pleural effusions as well, and they can have fluid overload. So one major thing is in complication is patient can have hypotension and lower the derangements in pulse pressure. So the diastolic BP initially can be higher in cases of compensatory shock, and once patient goes into overt shock, they can have overt lowering of systolic and diastolic pressures. So from a clinical examination point of view, you can look into the vitals, look for tachycardia, look for features of hypotension, hypotension, elevated diastolic BP, and features of bleeding manifestations, conjunctival suffusion, conjunctival, hyperemic conjunctiva, low sensorium, and muscle tenderness as such. And in the abdomen, they can have prominent right iliac fossa, right hypochondrial pain and hepatomegaly, tender hepatomegaly. Now, in the capillary leak phase, they can have ascites and pleural effusion as well. So these are the main things in a nutshell about the presentation and in the different stages.
Yeah. And with regards to fever, is there any specific pattern or something which is attributed?
Definitely. So the fever in dengue typically presents as saddle back fever. It is a biphasic fever. In the initial febrile phase, patient can have fever for 4 to 7 days, followed by a brief period where the patient becomes afebrile and later on develops a second bout of fever. So this is typically occurs as a biphasic fever.
Okay. To Dr. Naomi, something which is often asked first towards students is the WHO classification of dengue fever. If you can just enumerate on that.
WHO classifies dengue into 3 types.
Okay.
First one is dengue without warning signs. Second one is dengue with warning sign. And the third one is severe dengue fever.
Okay.
So the first one, dengue without warning sign, in that along with fever, 2 or more of the following findings may be present.
Right.
So the common symptoms are nausea or vomiting, rash, body pain, headache, elevated decreased WBC count, and positive Tonic Test. So any of these 2 findings along with fever, we can classify it as dengue fever without warning signs, or a lab confirmed test also can be used. In the second category, dengue fever with warning signs. So the warning signs are mainly any mucosal bleed, abdominal pain and tenderness, hepatomegaly more than 2 centimeter, liver enlargement, then any hematocrit, rapid increase in the hematocrit with a rapid decrease in the platelet count. So these are the some of the warning signs for dengue fever. And the third one is mainly the severe dengue, that includes the dengue hemorrhagic fever and dengue shock syndrome, mainly due to the plasma leakage, as well as the hemorrhagic manifestations along with other organ involvement. So these are the 3 main categories of dengue fever.
Dr. Maran, just continuing from where she left, she did mention something about the Tonic Test. So is it something which we do usually, or?
So Tonic Test is a bedside test to elicit the bleeding tendency in dengue. So it can be easily performed at bedside with the help of a sphygmomanometer. So the sphygmomanometer can be tied to the patient's arm, and the pressure in the bladder can be kept at pressure between the midway between systolic and diastolic pressure for 5 to 10 minutes. And what you observe is the appearance of petechiae over the brachial area. So typically some petechiae can occur even in normal individuals as well, but the presence of more than 20 petechiae per meter square implies that the patient is at a higher bleeding tendency. And even if the number of petechiae is between 10 to 20 also, it implies that it is the patient is at high risk. So it's an easy bedside test to clinically distinguish those patients who are at high risk for bleeding complications.
To Dr. Chinu. So what are the usual microbiological tests which are used to diagnose dengue fever?
Okay. So for diagnosis of dengue infection, you divide it as the tests that are available in the first week of illness. So those are the NS1 antigen detection, and here we are detecting the non-structural protein of the virus, and this is usually elevated from day 1 to day 7 of the illness. So after that, NS1 may not come positive. Then you have the PCR test. So PCR is you are detecting the viral RNA, and this also will be elevated in the first few days, that is in the initial 5 days of illness. After that, PCR also will not be very specific. And so these are the 2 tests that we do. Then you have antibody detection. So that is IgM and IgG detection. Now, for primary dengue infection, IgM is the one that is going to rise rapidly. So you will see the IgM rising from day 5 onwards, day 5 of illness. So before that it is NS1. So after day 5 you can see an IgM rise, and usually it lasts around 90 days.
Okay.
So then you have IgG. So IgG is in primary infection, it slowly rises. So it takes some time for the IgG to rise. So usually you will see the rise starting around second week of the illness. So second to third week you will see the IgG rising.
Right.
And maybe it's lifelong you will see a rise. There is a titer of IgG.
Okay.
Now whereas in secondary dengue infection, it is IgG that rises rapidly compared to IgM. IgM relatively remains low. And IgG, within a day or two, you will see a rise in the titer of IgG. So that will help you to differentiate between primary and secondary. Now, certain clinicians also use the IgG-IgM ratio.
Right.
That is to differentiate between primary and secondary. So a ratio of more than 1.1, they say. You can say it is more towards secondary.
Okay. Thank you. To Dr. Merlin, so she did mention about the microbiological test. So what are the other laboratory investigations which one should be looking forward?
When we concentrate on the bedside laboratory tests, other than what that is used for the microbiological diagnosis of dengue, we mainly look at those tests which can imply the complications of dengue. The commonly done tests are the CBC, the complete blood count, which includes the hematocrit values also, because it is an indirect measure of the hemoconcentration that happens in dengue.
Right.
In addition to that, we will look into the total count with differential count to look into the differential count which implies the total leukocyte counts also. So
Right.
in dengue there can be sometimes leukopenia and sometimes lymphopenia as well. And most importantly, the count will include the platelet counts. So the platelet count can be initially normal in the febrile phase and can undergo rapid decrease to very dangerous values as the disease progresses.
Right.
So after the initial febrile, the platelets will start to fall after the initial febrile, once the initial febrile phase comes to an end. And continuously we may require monitoring for the platelet counts thereafter, maybe daily monitoring of platelet counts or alternate day monitoring depending upon the patient's clinical status. If the patient is critically ill, we may even require to monitor them more than one time a day. So in addition to this, we will also look into inflammatory markers like ESR, CRP. Generally, dengue being a viral illness, we do not expect the inflammatory markers to be high.
Okay.
However, when dengue is having coexistent sepsis or
Right.
coexistent bacterial infection, which is very common, we will have high values of these inflammatory markers, and this gives us an indication to start antibiotics as well.
Okay.
In addition to this, you will look into the liver function test, that is, which will imply the hepatic functions, which includes the AST, the ALT, and sometimes dengue can have serious hepatitis, virus-related hepatitis as well, and RFTs, which include the blood urea, serum creatinine, and dengue with multi-organ dysfunction syndrome can have hepatic and renal involvement and
Okay.
derangement of these parameters.
Right.
Now, dyselectrolytemias are very common in dengue, especially hyponatremia, dyselectrolytemia involving potassium and calcium are quite common.
Okay.
So in the metabolic screen, especially in sick patients and patients who are admitted in the ICU, screening for these metabolic parameters are important.
Okay.
Dengue with hemorrhagic manifestation can have coexistent coagulopathy, which needs screening of the PTINR, APTT values as well. Now, in addition to all this, some additional blood markers like ferritin can give an indirect indication of dengue severity and can also imply complications like HLH, in which the ferritin values will be many-fold higher than the usual values. So, in addition to this, screening for acidosis with ABG may be required in critically ill patients, and screening for other complicating factors like high sugars and all would be necessary. Now, if secondary infection is suspected, you would also require cultures and the relevant markers like procalcitonin if a secondary infection with a bacterial pathogen is suspected.
Right. Thank you. So just continuing with you. What is the usual initial management for dengue which is done, and also is there any specific admission criteria set in?
Yes, definitely. So, dengue being endemic in our area and being a viral disease, it is very important to recognize who can be managed at a domiciliary basis and who needs to be admitted, and if at all requiring admission, who needs to be admitted at a primary or a secondary center, and who needs to have an early referral to a tertiary center, and even at a tertiary center, who needs to be admitted to the ward and who needs to have an early admission to an ICU.
Right.
So, dengue being a viral fever, essentially the treatment is symptomatic. There are no potential drugs with antiviral activity which are widely used.
Right.
So, essential treatment involves treatment of the fever, treatment of the symptoms like vomiting, nausea, treatment of the muscle aches and pains. In general, paracetamol is given in a TID dose for the fever and the pain. We tend to avoid NSAIDs because in spite of they being effective painkillers, they are very notorious to cause platelet dysfunction and can produce early bleeding in dengue. So in this particular case of dengue, NSAIDs and drugs like aspirin needs to be avoided. And IV fluids are cornerstones of management because the hemodynamic parameters in dengue is very essentially has to be maintained when the patient is admitted as inpatient. On a domiciliary basis, we encourage the patient to take lot of oral fluids and antiemetics and drugs for the associated gastritis and symptomatic management. Now, once the patient, domiciliary basis is advised for those patients who have mild dengue fever, who have fever with no warning signs. So the warning signs include, essential signs like bleeding, repeated nausea, vomiting, abdominal pain, especially right upper quadrant pain, features of low urine output, features of encephalopathy like low sensorium. These are all features of warning signs. So we should make sure that the patient does not have any warning signs and should be easily accessible to the healthcare system near them, and they should they should have their blood checks for their platelet counts in between. Now, for those patients who have comorbidities like diabetes, who are immunocompromised, who are post-transplant, who are on other medications, who can impair their immunity, or in those patients who have moderate dengue, who are at risk for hemorrhagic tendencies or at risk for severe dengue, as in pregnancy, as in patients who are having secondary dengue with initial, minor bleeds. They may be admitted at, they can be considered for admission at a primary or a secondary center. So at admission, essentially the line of management is antipyretics, IV fluids, and the IV fluids can be started at a rate of 6 ml per hour. And after 2 hours of initial admission, they can be screened for their hematocrit. Now, hematocrit implies hemoconcentration, and if we see that the baseline hematocrit is not coming down by 20% even after hydration, or the baseline hematocrit is going up, then that implies that the patient can land in complication and you need to transfer the patient to a higher facility. And in addition to that hematocrit, if the patient develops bleeding tendencies, then it is important to screen for their platelet count and to arrange the transfusions. Now, if the patient develops hypotension, again, and even before hypotension, features of low pulse pressure with high diastolic pressures, and also a positive Tonic test. All of this would imply that the patient may land up in complication and can consider early referral to a tertiary care center. Now, at a tertiary care center, the patient's vital signs really matter. So, at admission, if the patient is hypotensive, you have to consider ICU admission and stabilization, screen for hematocrit, give adequate fluid management, and watch for fall in the hematocrit. And if the hematocrit is falling more than expected, or if the patient is having overt bleeding tendencies, then we have to arrange blood transfusion. Now, the blood transfusion can be done as whole blood transfusion at a rate of 10 ml per kg, or can be arranged as PRBC at 5 ml per kg. Now, you can also consider the use of IV colloid when after the initial crystalloid therapy of 6 ml per hour is failing to produce a fall in the hematocrit and the patient is becoming hypotensive, then it implies that the patient is going into dengue shock syndrome. So there is something called extended dengue syndrome, expanded dengue syndrome, where the patient can have atypical manifestations like CNS manifestations, like encephalopathy, seizures, where the patient can have hepatitis, where the patient can have multi-organ dysfunction syndrome, and involvement of multiple syndromes. You should consider early ICU admission as well. And if the patient with dengue has concomitant sepsis as well, we need to give concomitant antibiotics and early referral to a center which can manage sepsis as well.
Fine. To Dr. Naomi, basically what are the public health measures or preventive measures one need to adapt in an outbreak of dengue?
So we have the National Health Program, that is the National Vector-Borne Disease Control Program. So the main three strategies under this program are early case detection and management. Second one is integrated vector management. And the third one is behavioral change communication. So the vector is mainly a daytime biter with the peak biting hours in the early morning as well as in the evening time. And they are nervous feeders. That means it requires more than one host to complete its blood meal. So there can be a rapid number of cases if the mosquito is infected. So vector control remains the main strategy for controlling dengue. So in this there are various measures. The first one is personal protective measures like use of mosquito repellents, patches, then sleeping under the bed nets, then screening of the doors and windows. All these things can be done. Then coming to anti-larval measures. Anti-larval measures biologically by the use of larvivorous fishes like guppy, gambusia, etc. And also by the use of Bacillus thuringiensis, which is also an anti-larval measure. Then chemical methods like use of oils, Paris green or Temphos granules in the surface of the water. Then environmental measures, this remains the main strategy for controlling dengue because they need artificial collection of water as a main source for their breeding. So we can do this by removing the artificial sources and by observation of dry days. So dry days are being observed by, previously it was only 1 day, now it is 3 days. So Fridays for schools, Saturdays for offices and Sundays for homes. So that can be done. Along with this, anti-adult measures. Anti-adult measures are mainly indoor residual sprays using malathion and space sprays using synthetic pyrethroids. So these are the main management measures. Along with this, health education and awareness should also be done to control the dengue.
Right. Coming back to Merlin. Merlin, you did mention about the various complications, including HLH and plasma leak and bleeding, etc. So, if you can just briefly tell about the management of these specific complications.
So, in dengue, one of the main complications include the bleeding. So, for which there could be bleeding because of thrombocytopenia, there could be bleeding because of coagulopathy, which is less common. So, thrombocytopenia needs to be corrected and bleeding needs to be anticipated. So, when patients are already on drugs that promote bleeding, as in aspirin or patients would have had NSAIDs, which may lead to platelet dysfunction. Bleeding can occur at cutoff of platelets, which is more than 20,000 as well. But in general, if the patient has not consumed NSAIDs or is not on any anticoagulation or any bleeding promoting drugs, the threshold can be as low as 5,000 to 10,000. So if the patient is clinically stable with no overt signs of bleeding, the patient can be observed till the lower limit of platelets can be as low as 5,000 to 10,000. Now beyond that, there is a risk of IC bleed, so we need to transfuse platelet concentrates to keep the platelet levels higher than the thresholds. Now, when the patient is admitted and the patient gets into hypotension, we may have to resuscitate the patient with IV fluids and have to discern whether there is an internal bleed. And once an internal bleed, like a GI bleed, is suspected, especially when the hematocrit falls drastically, then you may have to consider blood transfusion or PRBC transfusion. Now, the other dreaded complication is the capillary leak, which manifests itself as fluid collection, like ascites clinically as conjunctival suffusion, ascites, pleural effusion. So, in this capillary leak syndrome, it is important to keep the patient's fluid dynamics, very much balanced, and you have to include. You should not allow the patient to go into a volume overload, while optimally balancing the volume status with the help of the crystalloid, or you can use IV colloid as well. IV dextran also can be used. Now, when we go into complications like multi-organ dysfunction, like hepatic and renal dysfunction, the treatment involves the organ support, as in patient may have ARDS, patient may require invasive mechanical ventilation, patient will have low urine output with uremia and acidosis, patient may need dialysis support. So all these supportive organ support would be cornerstones of management in all of these symptoms. When the patient goes into HLH, then you can have a drastic fall in counts, along with drastic fall in inflammatory markers as well. And you can get a very high ferritin with organomegalies like splenomegaly and lymphadenopathy. And if we do a bone marrow at this stage, we can see hemophagocytic cells. Now, this is a very key stage at which we may have to give there is inflammatory overshooting, and we will have to give specific anti-inflammatory therapy as steroids. So what we advise is to give IV dexamethasone at a dose of 10 milligram per meter square. So for an adult of 50 to 60 kg, it will be like 20 milligram, minimum 20 mg of dexa per day for 3 days has to be given at this stage. So, and secondary bacterial infection always have to be treated with IV antibiotics, and other essential sepsis management has to be done as well.
Okay. To Dr. Chinnu, during your initial words, you did mention about the vaccines. So, what's the current status of vaccine development in Dengue?
So, because of the antibody-dependent enhancement that you see associated with different serotypes of dengue, it is very difficult. That is the major drawback of developing vaccines. So, currently only two live attenuated vaccines have been pre-qualified by WHO. So, one is the dengue vaccine. So, this vaccine is a live attenuated yellow fever 17D strain, which act as a vector. So this vector will carry the genes of all the 4 serotypes. So it's a tetravalent vaccine. So it has been approved for use in high transmission areas or high endemic areas by WHO in certain countries. In India, it has still not been approved because of the safety issues. So it is being given in people between 9 to 45 years of age. But the caveat is you should already have had a confirmed dengue infection.
Okay.
So in seronegative individuals, when you give the vaccine, there is a high risk of that person going into a severe dengue.
Right.
So that is a major drawback of this vaccine. So that's why I think even India has
not
not
popular.
approved its use. Then you have the recently in May 2024, WHO has pre-qualified another vaccine, that is the TAC-003 by Takeda. So again, this is between 16 to 20 years of age, but they say you can give for all those, you don't have to be seronegative or seropositive, but the efficacy we are still not very sure about this.
Right.
So those are the two vaccines that are available. Now in India, ICMR is in the process of a clinical trial of an indigenous vaccine,
Okay.
but we don't know the details of that.
Right. Okay. To Dr. Naomi. So, what's the importance of reporting and surveillance in diseases like dengue?
Being a disease of public health importance, as well as this dengue is hyperendemic in India as well as in Kerala. So surveillance is of utmost importance. So surveillance at the field level by peripheral health workers is being done as fever surveillance and case-based surveillance regularly.
Right.
And the cases are reported through IDSP portal
Okay.
from all the centers.
Okay.
So this is being done. Then district vector control team is there along with entomologists. They are visiting the field
Okay.
for source containment activities. So
Right.
this is also being done.
Okay.
Also, dengue is notifiable under the international health regulations.
Oh,
So there are certain categories. So we have to keep a watch on the entomological indices, vector indices like house index, container index, and Aedes aegypti index. That is the most important one. So also known as Bretto index. It should be kept under 1%. So
right.
along with this, at the seaports and airports, surrounding 400 meters should be kept Aedes aegypti free.
Right.
So this is also important. This is not only to prevent dengue but also to prevent other diseases like yellow fever, chikungunya transmitted by Aedes virus, Aedes mosquito.
Right. Last question to Dr. Merlin. What are the other differential diagnoses one should be thinking when a patient presents with symptoms which are looking like dengue?
Yeah. So, in an area where dengue is hyperendemic, we generally have a tendency to overdiagnose dengue. But there are other diseases which can present exactly the same way as dengue fever, even in the same areas. So it is very essential to keep the horizons open for this, so that some of these diseases may require specific management. So the important differential diagnosis of dengue fever, which usually presents as fever, headache, myalgia, arthralgia, is bacterial diseases which can present in the same way. Viral diseases which can present almost similarly. The bacterial diseases which can present in the same way include closely related leptospirosis, which is also endemic in our regions, and some of the rickettsial diseases like scrub typhus also can present with fever, headache, thrombocytopenia. This would remain, it's almost the presentation will be very similar in leptospirosis, rickettsial diseases and dengue fever. So it is very important to consider epidemiological clues like contact with brackish water or dirty water, or working in areas where the epidemiological risk of leptospirosis is high, or undertaking activities like trekking activities which may again render the patient more prone for rickettsial diseases. Now, history of recent travel is also important, especially while considering other bacterial agents like endemic fever, which is also quite common in our area. Now, fever with signs of jaundice is quite common with hepatitis syndromes, especially with foodborne hepatitis. So it is always essential to have these differentials on board. And also, in addition to that, fever with arthralgia and thrombocytopenia can present in other viral illnesses like influenza, chikungunya as well. Now, it is always essential to have diseases to rule out diseases like malaria, which can present exactly the same way as a dengue fever, and where key antimalarial treatment, the antimalarial treatment has to be given early in the diagnosis to avoid complication. And in all other diseases like leptospirosis, enteric fever, etc., the antibiotics are important. So it's always important to consider them. And one another, non-infective, we have to always also consider non-infective differentials like acute leukemia, which may present similarly like fever, myalgia or arthralgia with thrombocytopenia, low counts or slight variation in counts. So always do a peripheral smear when epidemiological things are not matching and something goes out of the way. So always keep these differentials on board, especially when considering dengue.
Okay, right. Thank you. So one last round of questions to all of you. So from the undergraduate level, is there any questions they can expect from dengue, from medicine exams?
Definitely, when dengue is so much of dengue is around, they should expect questions on, they can expect a clinical question on dengue with, with focus towards, the diagnosis and management and management of complications. I think it can be an essay question for them, or they can have short questions on, the complications of dengue, the classification of dengue as well. So from
community medicine, yeah.
So from community medicine, as we know, epidemiological triad, agent, host and environmental factors are important. Then the classification. Then case scenarios can be given as a structured essay question. And importantly, the vector indices and integrated vector management, and the National Vector-Borne Disease Control Program is also important.
Perfect. Right. Microbiology?
From microbiology, again, dengue can be a structured essay. With they'll ask you like differentials, then why you say it is dengue, and how do we diagnose dengue, and about vaccines, they can all ask that.
Okay, right. So thank you all. So I believe we had a very, very engaging and knowledgeable discussion today. Thanks.